Hi, I'm Amy Reyes. This week for Rheumatology Network, we continue our series on osteoporosis with two study briefs. One from the Archives of Osteoporosis shows that patients with hip and spine fracture rarely have normal bone, even when DEXA scans say otherwise. And we featured a study that shows the long-term use of corticosteroids by older women does not increase their risk of fractures. And in rheumatoid arthritis, a study published in the Journal of Annals of Internal Medicine shows that taking low-dose methotrexate may lower the risk of developing skin cancer, gastrointestinal infections, pulmonary disease, and hematologic conditions. And a study from the journal RMD Open shows that a rheumatoid arthritis diagnosis does not increase the risk of death in patients who are hospitalized with pneumonia, but this applies only to RA patients with controlled disease activity. And researchers writing in Nature Reviews Rheumatology report that rheumatoid arthritis patients have nearly a double risk of cardiovascular disease, stroke, heart failure, and atrial fibrillation, but they receive poor primary and secondary preventive care than other high-risk patient groups. And we talk with Dr. Kennedy Emerald of Brazil. He is an expert in the mosquito-borne chikungunya virus, which can lead to a type of arthritis often mistaken for rheumatoid arthritis. We published a Q&A this week with Dr. Amaral, and he highlights the difference between the two types of arthritis. And finally, in today's one-on-one interview, we talk with Dr. Vibeke Strand, an adjunct clinical professor in immunology and rheumatology at Stanford University, and a biopharmaceutical consultant who has conducted studies on JAK inhibitors. Today, we're talking JAK inhibitors for rheumatoid arthritis and new findings from the journal Arthritis and Rheumatology that shows it has a great deal of promise as monotherapy in rheumatoid arthritis. Welcome, Dr. Strand.
So my full name is Vibeke Strand,
Mm-hmm.
and I'm an adjunct clinical professor in the Division of Immunology Rheumatology at Stanford. And I also work as a biopharmaceutical consultant in new product development in rheumatology.
Okay, so today we're talking JAK inhibitors.
Yes.
This phenomenal study published in Arthritis and Rheumatology, reporting on the, I think it was called the SELECT trial.
No, SELECT is the phase 3 program for upadacitinib. So this was called the early trial.
Okay.
So they call it SELECT early.
Okay. And it was a report as a JAK inhibitor as monotherapy in patients with moderate to severe active early rheumatoid arthritis. And the results were pretty good, right? They achieved their primary endpoint and second endpoint. Yeah. How significant is that for a JAK inhibitor?
Okay, so it is very significant. So we go back a little bit. These are methotrexate naive patients, or if they'd had some methotrexate, it had been for a very short time. So now we're talking about, can a JAK inhibitor actually, as the first DMARD, be better than our standard DMARD, our first conventional synthetic DMARD, which has always been methotrexate? So the answer is yes. Not only was it non-inferior, but it was actually superior to methotrexate by every endpoint they selected in the whole trial. So ACR 50 was the primary endpoint for the US and for the FDA. But DAS remission, ACR 50 at 12 weeks, but DAS remission at 24 weeks was the primary endpoint for the EU. So they met both of those. First you test for non-inferiority, then you get superiority. But then they had it also by the SDI and the CDI, which is low disease activity and remission. They had it by X-ray at 24 weeks. They had it by the percentage who showed no progression in their X-ray scores. They had it by many of the patient-reported outcomes, which are secondary measures, but they'll be summarized in another manuscript, which we just finished.
I see.
So it's not included here. But compared to other JAK inhibitors, they've all been shown to be superior to methotrexate as monotherapy.
Mm-hmm.
Okay. So, although this is very important data in the context of it's very consistent across all the endpoints, it's about the fourth, essentially the third JAK inhibitor to show this. So tofacitinib was the first in their START trial.
Mm-hmm. Mm-hmm.
Okay.
Okay. Mm-hmm. And
Now,
mhm,
I'm
I'm sorry.
sorry, I'll let you ask the questions.
No, I'd much rather hear your explanation. This is fascinating. I was just wondering, how important is this in terms of maybe reconsidering how or what our first line therapies are? I know ACR recommends methotrexate, and it works in some patients, it doesn't others. So there's this step process to try other medications, maybe biologics. So, what should doctors do now that they're seeing this study and these phenomenal results? Mm-hmm.
Well, it's a very good question. It's probably the most important question you could ask.
Mm-hmm.
So we have 30 years of using methotrexate as our first DMARD and at one time our only DMARD. So it's something we know well, and it's something we know how to use. And we pretty much worked out how to dose reduce in patients who have intolerance and whether you can use sub-Q if they have problems with nausea and GI symptoms and so on. However, what we're seeing with the JAK inhibitors across all of them, we have data with 4 of them now. So we have filgotinib as well as upadacitinib, as well as baricitinib and tofa, is that the JAK inhibitor efficacy is evident between like weeks 1, 2, and 4. So it works much faster than methotrexate to a higher degree early. So patients know they're getting better because their pain starts to get less sooner. And there are other measures of fatigue and global, how they feel globally and so on, their physical function start to improve so much earlier. So that's one argument for why it would be nice to have a JAK inhibitor be the first DMARD. Another argument is that they're much better tolerated. So they don't give the GI symptoms that methotrexate does. You don't have to worry about alcohol intake, which, many arthritis patients aren't alcoholics, but they like a little bit of wine or whatever for some pain relief at the end of the day. And they get afraid about it with methotrexate. And then finally, I think the other point really is that convenience, because people will say to you that it's maybe easier to take something once a week, but you may also forget to take it. And one of the issues about the tolerability of methotrexate is that after you take that big dose once a week, you usually don't feel very good for a day or two. And patients have learned to maybe separate out the doses a little bit so that they don't get so sick from it, and so on and so forth. But when a patient is able to get off of methotrexate, they almost invariably tell you how much better they feel.
Mm-hmm.
So it's an important point. So the issue is, can we use it first? Are we allowed to use it first? And the answer is not by the labels that we have by EMA or FDA. But clinical practice can dictate that if you want to do this, you can do it. And so that's always the sort of if in the US. If clinical practice dictates that you want to do something that's off label, but it is within the realm of what other rheumatologists are doing, then it's conceivable. But then we get into the issue of how much does it cost? And it's not how much it actually costs, but it's how much the insurance companies charge the patients, or how willing the insurance company is to make the therapy available, and to make it available, say, before methotrexate is tried. So many of them require that you have to have methotrexate first, because they can choose what the first therapy is. They can't usually choose the subsequent therapies, except in terms of cost to patient, co-pays and all of that. But they can more or less dictate what's the first therapy that follows methotrexate, or whether you can skip methotrexate.
Mm-hmm. Let's go back to insurance companies and the cost, though. You know, biologics are not cheap. They can cost thousands of dollars a month. And do you know, is this something that JAK inhibitor, since it's relatively newly approved, is this something that they would cover off-label?
They do.
Mm-hmm.
They do. Increasingly, we're being able to use these JAK inhibitors after a relatively short period of time demonstrating failure of methotrexate,
Mm-hmm.
or even without taking methotrexate.
Mm-hmm.
It's a little harder to do. We have to write more prior authorization requests, but it is doable. The problem for us is that we don't actually know how much these medications cost the patient.
Mm-hmm.
We have no idea what the copay the insurance company is going to require from the patient. Or if they're not going to have help from insurance, are they going to have help in terms of Medicare, or in what we call in California, Medi-Cal, which is help to the indigent essentially? Or are they going to be eligible for one of these patient aid programs that all of these companies have, the JAK inhibitor companies as well as all the biologics? And so that may mitigate against also whether it's going to be too much of a cost to the patient.
Mm-hmm.
But the issue about all of these things is what's accessible to the patient. And for instance, if they're in a university setting, they may not know about these copay or actually patient help programs from the sponsors, because the sponsors don't actually come to our clinics to tell us about these programs. So then the patients have to be smart enough to nose around or be part of a community to find out that these kinds of programs are available.
Mm-hmm. Yeah, a little detective work. Yeah.
A lot
Yeah.
actually.
Right. Mm-hmm. It sounds like a long process, a very long process. It could take months.
Well, it
By
can
then.
be a very long process
Yeah.
because patients find out how much it costs and they're freaked out about it and all of that, and they may not fill the prescription. But the other part of these copay aid programs that each of these companies has is to actually help patients get through all of that red tape. And they actually assign nurses to these individual patients so that patients can connect with someone who will actually walk them through all of the paperwork and all of the other issues and help make sure that they could get the medications.
Right, like a patient advocate would. Yeah.
Exactly. But we're kind of kept in the dark about this, just like we don't really know what these different therapies cost to the patients.
Mm-hmm.
They don't make any of this stuff very clear to us. And usually we don't have a lot of time when we're seeing a patient to spend on what's going on with how are you paying for this.
Mm-hmm. Right. Yeah. It sounds tricky because you want to be able to get those medications before you flare,
Yeah.
and it continues to progress. And
Yeah.
you might take one biologic, and then you might want to switch to a JAK inhibitor if it doesn't work. So it makes things a little complicated.
Well,
Um,
there is a lot of switch. It's very complicated
mhm,
because there's lots of different therapies. Biologics are expensive, all of that.
mhm,
But the other thing is, we know in rheumatoid arthritis that by and large, at the end of a couple of years, about 50% of patients will have switched to another therapy. Usually not because of adverse events, usually because of either loss of response or decrease in response or some other reason, which
mm,
is very interesting. Now, thankfully in RA, we have so many different therapies, but psoriatic arthritis, we have fewer. Spondyloarthropathy, we have fewer. And so this is an issue. And there's less switching in Europe because there's more control over, one, what can be used, but also the biosimilars have penetrated so that they've offered profound cost savings, which we really don't have yet.
I see. And I understand that biosimilars are really not being prescribed and the numbers we expected in 2020. The doctors and patients
Well,
are still a little reticent.
that's true. The problem is that there's 5 TNF inhibitors. There's biosimilars available for essentially 3 of them, but for 2 of them, they're not allowed on the market because of patent fights.
Mhm,
So we really only have biosimilars for infliximab, Remicade, which is an IV therapy,
mhm,
and the adalimumab, Humira, and the etanercept, Enbrel biosimilars won't be available to us to use until 2021, 2023.
mhm,
And that is where the enormous cost savings really will be,
mhm,
because within rheumatology, most of the therapies we use are sub-Q or oral.
mhm,
So then we get back to the JAKs because people like oral therapies. Some people like sub-Q because they think if you inject it, it'll be more effective. But lots of patients like just being able to take a pill.
mhm. Yeah, which is one of the great pluses of the JAK inhibitors. They are currently approved for what conditions here in the U.S.?
So 3 of them are approved for rheumatoid arthritis.
Mhm,
Tofacitinib is approved for psoriatic arthritis and for ulcerative colitis.
mhm, mhm,
Okay. The others are moving along. I think the next approval we'll see is psoriatic arthritis with upadacitinib, because they just finished phase 3 trials in psoriatic arthritis. We should be seeing something happening in psoriasis. Tofacitinib had a successful clinical development program, but was not approved because of safety concerns on the part of the FDA,
mhm.
which I don't think most of us necessarily share, but it's a complicated question.
Yeah, yeah, yeah. So in terms of next steps for this trial, you mentioned there's another manuscript you just completed. And should we expect other big news for JAK inhibitors this year?
So I don't know when filgotinib will get approved for RA.
Mhm,
I suspect that those discussions are very much underway right now with the agency,
mhm,
but they have a couple of issues that the agency is concerned about. I don't know how quickly the psoriatic arthritis approval will move, but the PSA trials that were presented at EULAR were quite successful.
mhm,
Um, we also know that spondyloarthropathy is being pursued by TOFA as well as upadacitinib and filgotinib. Um, it's kind of hard to know what's going to come next, other than the ones I just mentioned to you.
mhm,
But there's work going on in lupus as well.
mhm,
And we have some combination JAKs that are being developed as well.
mhm. Some combination therapies with,
The JAK inhibitor plus a BTK inhibitor, as an example,
mhm,
or a JAK inhibitor with a TYK2 inhibitor,
mhm, mhm.
with the idea that they may be more, quote, selective for that disease.
Mhm. A
But
rheumatic
the
disease.
argument against that is
Mhm,
that so far we have 4 JAKs, and the second 3 are probably more selective than tofacitinib.
mhm,
But clinically, they behave more similarly than they behave differently.
mhm,
So it's really hard to say that that the selectivity or even a combination is going to be better between one and another.
mhm. That'll be interesting to see. Those
Yeah.
papers will be published this year?
No, the combination trials are just really getting underway. So
Yeah.
we're not going to see a lot of data with them yet. There's going to be a couple of years.
Yeah. Mhm. Okay. Well, I'll look for those. Yeah, yeah. So, well, I think this is news we should be excited about, though. The JAK inhibitors, the path looks good. New treatments are needed. Patients don't respond to they don't respond the same. They're all different.
That's exactly right. So
Mhm,
we have huge individual variability. And just like somebody can respond to a second TNF inhibitor when they didn't respond to a first one, we do have a difference though. If you fail a first TNF, you're much less likely to respond that well to a second TNF. Now,
mhm,
so far, we only have anecdotal data with the JAKs, but it very much appears like if you fail one, you have just as good a chance to respond to a second one, just as well as you might have to the first one. So when we're going to have 4 of them to choose from just in rheumatoid arthritis, I think you're going to see that they're going to really gain a lot of the therapeutic, shall we say, pie.
mhm,
The problem is that people are still worried about DVTs and PEs,
mhm,
deep vein thromboses and pulmonary emboli.
mhm,
And that the FDA has considered those to be a class effect,
mhm,
so that that's what the labels say,
mhm,
essentially. But many of us are not convinced that that's true. Many of us think it really reflects the underlying comorbidities of the patient population,
mhm,
because DVT-PEs are more common in RA patients,
mhm,
as well as lupus and several other diseases. But the other point is that essentially what we also know is that the majority of patients who've gotten these events in randomized trials are people who had a prior event. And so they were much higher risk for a subsequent pulmonary embolus or deep vein thrombosis.
mhm,
So it's very hard to clearly understand what the true risk is, how much of it's the underlying disease, and how much of it's the therapy.
mhm, hmm. That would explain why readers have such a great interest in those two subjects. We write about them extensively, the lung disease and
Yes,
pulmonary embolisms. That would explain its continued interest here for us and for our readers, and we'll continue to follow that and all of these developments. Is there anything else you'd like to leave us with in closing?
um,
I know there's so
just
much
that I
to
think
say. Yeah.
it's really nice we have 3 of these.
Mhm.
I'm trying more and more to use them earlier, but I guess the other point is that they work very, very well in people who failed multiple biologic DMARDs. So they can be used early, they can be used late. And it doesn't appear to matter very much how many therapies somebody has failed as to whether they're going to respond well to a JAK.
Mhm. Well, thank you. Thank you on that note. I appreciate your time. This has been wonderful. I've learned so much from you in this time that we've been talking, and hopefully we'll be able to talk again. Yeah.
Sure.
Um,